Thank you very much. Patrick, you're chief resident?
No, I'm here. I'm in my second year of research.
It's like you crushed it. Just an amazing talk. So I wish I could even speak like that when I was at your stage. So I'm going to talk about hernia apps. There's not that many. I'm going to roll through some of this, and we'll see where we get. The typical way of disseminating information is this. And of course, I grew up with this. You read a paper, and then the consideration of is how much you actually remember. And then how much you remember, how much you input into your patient care. Certainly, there are better ways to do this. And Paul Bleecker came up with the idea that we needed to essentially develop predictive modeling by data. Big data, we're getting more and more big data, but big data itself is not enough. Absolutely, there's a difference between truth and knowledge. And so when I look at the difference between truth and knowledge, I will say that certainly plural is not the antidote of data, observations are not knowledge, but certainly the real test of knowledge is utility. If someone gives you something, impacts you with knowledge, you need to be able to input that into your patient care without question. And I think that truth actually may be a poor measure of knowledge. In this review from MIT, they said that there was a lot of data being gathered, of course, and it's really about coming up with applications to make this data actionable. And that's why it has happened, as you've just seen, but also what we've done in hernias. The first app that was a hernia app came out in 2012, and then we did this looking at quality of life after inguinal hernia repair. What stimulated us to do this is if you looked at the most common reasons that surgeons were sued in hernia repair, it had to do with quality of life after inguinal hernia repair. Less than 8% of surgeons were actually, in the consent process, were talking about chronic discomfort after hernia repair. Came out in the Wall Street Journal, among many other journals, talking about be careful about who does your hernia repair, the secret of hernia repair, and it was dragging down hernia repair in general. So what we did was we took the International Hernia Mesh Registry, greater than 35 centers, and we inputted this data, and what we saw was the world is a small place in fixing hernias, and you can see the recurrence rate is actually pretty darn low. But then if you go through and look at the chronic discomfort, small recurrence rates, open and laparoscopic, it didn't matter, Europe, the United States, but the chronic discomfort or pain in these patients was real. And so what we did was we took 1,700 patients, we had 3.5 million data points, did a multivariate logistic principal component regression, and what we found was these are the factors that impacted postoperative pain. So we essentially just made a mathematical equation. And if you look at it, if you want to write it down, this is the mathematical equation if you'd like to write that down and input it in your clinic. So we actually have a medical student who actually sits and knowing that we don't actually. But this would be really difficult to actually, so this might be truth, but it is not knowledge. And so you actually take this and then you input it into a functional app. And then indeed, perhaps you can help people. So we came up with this app. Now when I have patients who talk to me, I talked about every single patient about the possibility of chronic pain. And now if they want to know what their chance of chronic pain is, we can actually predict this very closely. And so this app, when we first launched it, it was one of the first medical or surgical predictive apps in the world. It's been downloaded in more than 140 countries. And interestingly, in 2012, the Wall Street Journal listed it as the #6 way that patients are getting better treated because we talk to our patients effectively using big data. We then came out with something called the Cedar App, and the Cedar App, of course, deals with wound complications, the bane of my existence, and abdominal wall reconstruction. Loads of wound complications in these patients, and of course the wound complications are high. It increases the risk of recurrence and reoperation costs, and then just kick the patient down the rabbit hole. So we did essentially exactly the same thing. These are 501 of our own patients, more than 1 million data points, and then of course you can see the area under the curve. We actually predicted our outcomes pretty nicely with this app that we developed. These apps are free on iTunes and the Droid store. We then really wanted to check and make sure it wasn't a microcosm of Charlotte. So this is looking at the Greenville Hospital System. We looked at 915 of their patients, and we actually predicted their outcomes better than our own. But what we're able to do with this is we can take a patient who has, like say, a BMI of 40, a smoker, a diabetic. We're going to have to do a component separation and advancement flaps in this patient. If you add all this up, the 70% wound complication rate. Somebody at the University of Tennessee, when I gave grand round, said, wow, that is a really high wound complication rate. Where did that come from? I said, me. Because we used to just operate on these people. And everybody now says, oh, I would never have operated on that person. Yeah. But now we can actually talk to the patient. We can say, look, if you'll drop your BMI to 35, become a non-smoker for 4 weeks, drop your hemoglobin A1C to less than 7.2, we can drop your chance of wound complications to 23%. So we use this for counseling of our patients to demonstrate how we can improve their outcomes. And this is our data using our app. This is 501 patients. This is the next 713 patients. And we decreased our complication rate by more than half. And it was an estimated savings of about $4 million. John Fisher at the University of Pennsylvania has come up with an app now where they actually predict the chance of developing a hernia. Fantastic work. And am I jealous? Heck yeah, I'm jealous. You know, the plastic fish, that guy is a remarkably smart person, has written a ton of papers, and really does a great job interfacing not only with patients, but also with other physicians and making us all smarter. Another one of his papers, and if you look at the trend, we're increasing the trend of hernias in this country. I don't care about robotics, I don't care about laparoscopy. Is the increasing trend of hernias in this country? Absolutely. We're discharging more people with hernias, and we're fixing more hernias, and it's a revolving cycle. And if you look at it in 2011, it's estimated there were 100,000 true ventral hernias, incisional ventral hernias, at a cost of $7 billion. So the best way to do this is prevent it, as John says. John, these are slides from John, and I want to thank John. He presented this at the American Surgical Association. But what they looked at University of Pennsylvania, and 3.8% of their patients with follow-up developed a ventral hernia. And if you look at, this is some of the data that they generated in forming this app, loads and loads of data, and then they started looking at the p-values, and they started being able to weight the risks in this analysis, and now you can start to develop a scoring system after you've weighted the risks. And so what John did was he broke it down into low, average, high, and extreme cases. And where he really wanted to focus is in these groups. So if we can predict who's going to develop a hernia, then maybe we can do something to try and prevent them. And so his secondary considerations in this was looking at what the index cost of incisional hernia repairs per patient was about almost 50 grand. Readmission cost was about $26,000. And the combined cost of care per patient was about $57,000 per patient. Extraordinarily expensive. So at the University of Pennsylvania, 3,600 hospital days and $62 million. So indeed, it demonstrates how difficult this is. Of course, this is your mathematical equation. If you don't want to use the app, you can just write this down and put this together for your own patients individually in your clinic. But this is what the app looks like. This is going to be the background of the app. And this video over here is going to be the app itself. It's free. You can look it up under UPenn Hernia. I think it's fantastic. And we talked about this morning in a program, if you want to use MASH to prevent hernias, I would absolutely, if you're going to prevent hernias, I would use this app and I would document it in the chart and then have the discussion with the patient. And so this actually works beautifully. Actually, in this patient, you can see it actually, if using this equation, the risk in this patient was about a 9.3% chance of developing an incisional hernia after the patient's colectomy. And so absolutely, we need big data, but big data has to be functional. One other app that most of us will not know about is an app we've just launched. This is pretty exciting for us. It's only available on an iPad, not an iPhone, and it's called the C-SPA app. And I asked him when I gave grand rounds last, I said, look, if you're going to do an anti-reflux operation on me, say a laparoscopic anti-reflux operation on a 50-year-old, what labs are you going to get? Are you going to get a chest X-ray? Are you going to get an EKG? What are you going to test in me? And I got a scattergram of information. Let me just tell you, I took a big run yesterday. I take no medications, and I have no medical problems. The answer is you would do nothing for me. Instead, no one said that. No one asked me what my Mets were. So I have to give Tiffany Cox, my son actually worked on this, and Kira Huntington, one of our other residents. Tiffany Cox is one of our fellows. We talking about doing this over and over again. We went through this 53 times before we came up with this app. And if you look at the needs assessment, we spend about $765 billion a year in excess healthcare spending. When we do preoperative testing, about 70% of it doesn't do anything for us and is unnecessary. And if you look at the American Board of Internal Medicine, American College of Physicians, European Federation of Internal Medicine, the top 5 things to save money, 2 of them have to do with preoperative care. And so we've got these guidelines, but the thing is no one uses them, no one reads them. And so these are the frequently ordered tests prior to surgery. And so we actually looked at our operating room, not only could we save money by using this app, but we could prevent cases from being canceled. We had 409 cases canceled in about a year and a quarter. If these were just hernia operations worth about $14,000, that's almost $6 million in canceled cases because they didn't have appropriate testing. We estimated we would save about $11 million in testing that was unnecessary, so about $17 million. This doesn't even include delayed cases and what delaying cases would be worth. 100 delayed cases worth $900,000. And so I'll just cut through this very quickly. People don't know whether they get an EKG or not. They'll just order one so their case isn't canceled. This is the algorithm for an EKG. This is preoperative echo. And so what we've now done is we'll actually hand the app to a patient. They'll fill this out. It takes me about 90 seconds to check it, and so we can see what their graded risk of surgery is, what their ASA score is, what their risk of cardiac event is, and then this will tell us down here, tells us what labs to order in these patients. And then if there's a real question about it, you can actually just touch this button on this side, and it will actually give you the data to support either not doing something or to do something. So anyway, I'll stop here. We'd actually tested this in our office on 350 patients. We averaged saving about $579 dollars per patient for a tremendous money savings. Thank you very much.